My name is Matt Blois. You're listening to Medically Necessary, a podcast about the healthcare supply chain. On the show, I talk with experts, business leaders, and researchers about how we get drugs, devices, and medical supplies to healthcare providers and patients. This podcast is brought to you by Ryder, the only fully integrated logistics and transportation provider in the industry. Ryder solutions cover the entire supply chain, including warehousing, transportation logistics, e-commerce fulfillment, and last mile. Discover how Ryder can make you ever better at Ryder.com. So millions of Americans are getting COVID-19 vaccines from retail pharmacies or mass vaccination sites, but those locations might be hard for some people to get to, especially... Sorry. I think I had to start this whole thing over. Sorry, guys. My name is Matt Blois. You're listening to Medically Necessary, a podcast about the healthcare supply chain. On the show, I talk with experts, business leaders, and researchers about how we get drugs, devices, and medical supplies to healthcare providers and patients. This podcast is brought to you by Ryder, the only fully integrated logistics and transportation provider in the industry. Ryder solutions cover the entire supply chain, including warehousing, transportation logistics, e-commerce fulfillment, and last mile. Discover how Ryder can make you ever better at Ryder.com. So millions of Americans are getting COVID-19 vaccines from retail pharmacies or mass vaccination sites, but those locations might be hard for some people to get to, especially if they lack transportation or have mobility issues. In response, some organizations are looking for creative ways to reach those people. For example, in March, the Federal Emergency Management Agency launched mobile vaccination units that go to where patients need them. Today, I'm talking to Jason Rose and Paul Shelton, two leaders with the telepharmacy company AdhereHealth. So normally, AdhereHealth focuses on making sure patients avoid health problems by correctly using medications. But in March, the company set up a new program to help states vaccinate hard-to-reach populations by addressing social determinants of health. It could mean educating patients about vaccines, arranging transportation, or answering questions about prescriptions. I brought Jason and Paul on the show to talk about what works when it comes to vaccinating people who might have a hard time getting into mass vaccination sites, and what those efforts might look like now that the vaccine supply is starting to surpass demand. So Jason and Paul, thanks for joining me on the show. Can you just start by telling us what your company has been doing to help out with the vaccine rollout?
Hi, good morning, Matt. Thanks for inviting us on your show. We've been focusing on how to prepare for the vaccine rollout for the past several months, and also how to configure our technology in our telepharmacy outreach program, as well as our pharmacy itself, to vaccinate patients in person. And so over the last several months, what we've been focusing on is building a configurable tool that in the past reached out to patients telephonically through our telepharmacy team. We have about 1,000 clinicians, most of them pharmacists and pharmacy technicians, that identify who is the highest risk patient for COVID with particular diseases, particular areas of the country, the underserved, the most vulnerable people, and how can we identify them and prioritize them so that those patients are going to get vaccinated and overcome social determinants of health. That's issues with food insecurity, transportation, access to medications, access to their doctors, access to vaccination sites, vaccination hesitancy. And so what we've been doing is preparing the technology, and now over the last few months, implementing that technology and the telepharmacy team to identify and prioritize those patients that are having challenges getting vaccinated. And I would say that was the first thing. The second thing we've been doing, in addition to that, is preparing our pharmacy teams to be able to set up mobile clinics in rural areas of America, in addition to providing in-home vaccinations for patients that are homebound. And so we've been preparing both of those in terms of how we can both best support the vaccination rollout. So over the last few months, we've also been working directly with the Centers of Disease Control, the CDC, through our federal partner, which is Jeramed, to access vaccinations. This is the J&J. We started with J&J and Pfizer. We've now just added Moderna in terms of the actual access to allocations of these vaccinations above and beyond what the states are getting from the federal government. And because of our unique focus on the underserved, the rural areas, the homebound patients, the CDC, through our partner Jeramed, has granted us access with pallets and pallets every week of these vaccinations to get to these most underserved markets. And then with all that said, finding partners, whether it be large travel stations or dialysis clinics or primary care physicians, rural health, churches, social gathering areas, employers, and getting these mobile clinics set up so that we can actually vaccinate these patients who are really at the highest risk in terms of getting vaccinated.
Yeah, yeah. I think that's super interesting. So it sounds like you were saying, you have this partner where you're getting vaccines, and it sounds like. So I think the question I had there, based on what you were just saying, is how do you pick where the vaccines go? Because it sounded like you don't necessarily know, super far ahead of time where you're going to set up a vaccine clinic and who you're going to be vaccinating. So how do you decide, where's the best place to go? I mean, you mentioned some of these places like, travel centers or churches or places like that. So how do you decide, like, this is the place we're going to go and these are the people we're going to vaccinate?
Well, we're able to, through our analytics, we're able to identify, kind of macro level locations in advance. So I wrote a white paper a couple months ago. It's not the genetic code; it's the zip code. So that applies not just to medication access and access to care. It directly applies to vaccinations as well. So we could tell, frankly, a year ago where there were likely going to be areas of the country that were going to have higher hotspots for COVID problems, because these are the same patients that were not getting proper care and getting access to medications. It happens to be the same places that are having problems getting access to vaccines. So at a macro zip code level, we're able to pinpoint that very well. And then when we get into the details of specific where is the best place, that's more of a detailed logistical area. And I'll ask our head of pharmacy, Paul Shelton, to add some more color to that. Paul?
Yeah, so what we do, Matt, is we look at those macro level zip code areas, the specific regions or counties in the state where we know that there's additional demand for both our ability to get out into the space, easy low technology access point, which many of the local mass vaccination clinics, you had to have a smartphone or you had to have access to the internet to sign up for an appointment. And so what we're trying to do is get access to folks who may not have that ability, whether that's through a local partner organization such as a church or area communities and ministry, or working with local community centers that say, okay, I have patients, but they don't have the ability to sign up through this process. And we'll find a logistically suitable location within the county, and we'll create a hub out of that location. And that will be I think of it as a mini mass vaccination site. So maybe 150 to 200 opportunities for someone to get a vaccine in that location. And then depending on demand, both through our partner health plans and then also through our own patients in the area, we'll field an additional number of clinicians who are actually going into patients' homes and providing at-home vaccinations for the most medically fragile patients and the patients who have the least opportunity to get out and actually get vaccinated on their own.
And just to add to that, what Paul was describing might help characterize it. It's really what, and Paul coined this, it's a hub and spoke model. So the hub is the location. Let's say we're at a parking lot of a ESRD clinic in a rural area or a travel station or a church. That would be the hub. The spoke is we are both putting the word out to get employers, patients, managed care plans to send us or transport patients to that hub. But we're also in turn taking the spoke also to the patient's home itself in the last mile, so to speak. So actually going to the patient's home who can't leave their home and vaccinate inside the home, and that would be the spoke. That makes sense. With I think a 15-mile radius.
Yep. depending on the market, 15 to 20-mile radius. And the reason that's so important, Matt, is the vaccine is not stable outside of refrigeration for extended periods of time. And so that hub gives us a forward deployed location where we can go and we can have a clinician grab 2 to 3 doses, go out to a patient's home, provide those doses to everyone in the residence, come back and pick up more vaccine and go back out to the next patient's home, or grab several and hit in small clusters around that area.
Yeah, but it allows them to do those sort of short trips, and so it's
Correct.
time-wise, the vaccines are not out of refrigeration or freezers for very long.
That's correct. Yes.
But yeah, that totally makes sense. Kind of two levels of things you guys are doing there. That first level is sort of helping people who, they can get to somewhere that's close to them pretty easily. They've got a car. They just bringing it physically closer makes it easier. But then there's that step of going, okay, like, even though we're a mile down the road from you, like, you're going to have trouble getting here because it's hard for you to walk or drive or something. So, like, we're just going to bring it to you, and we're going to work with people to make that happen.
Yeah. Or another example, Matt, is we've also worked with a home food delivery company. So we know their route. And so we follow their route with our nurses they deliver the food. We're right behind them when we're vaccinating them. And then we also have those transportation companies that transport patients to their care, working with them to transport those same patients to our hub as well. So that would be another couple examples of that supply chain.
Yeah. You're talking about like working with like non-emergency medical transport type
Right.
That's correct. Yep.
Yeah.
That's correct.
To get them to figure out, okay, who do you guys normally bring to the doctor's office? They're probably going to need a ride to get a vaccine too. And
That's right.
we can help with that.
Yep. That's correct.
So, I mean, that's already starting to get into a little bit of this question, but, I think we've heard about, I think it's all states now are open up to anybody over the age of 16 can go get a vaccine or at least is eligible to. So I think some people might have the impression that, if you want a vaccine, you can just go out there and get it. But, who are the people that are still struggling to get vaccines right now, and why are they having a hard time?
Yeah, it's a great question. I think it's multifaceted. What we're seeing is in rural areas, for example, whether it be North Carolina, Tennessee, a couple examples, or Virginia, some of the kind of local surrounding region of where we are here. Those rural areas are having just getting access to the vaccination itself because it may be easy for me. I'm in greater Nashville. It's easy for me to drive 45 minutes in my car and get to a vaccination site or even the local Walgreens or Kroger or what have you. But if you only have one pharmacy in town and one internist, and they don't have enough supply on hand, then there's no schedule to be had. And maybe they can schedule weeks in advance. By the time they get the supplies into their pharmacy, they can schedule it. But we're seeing, even in the last, call it 10 days, they still are having problems with access in those rural counties. So I would say that is still a problem. So the areas that are more populated are getting more supply. The more rural areas are having problems getting the supply itself. The second part is that there are a number of people, whether it be in the rural areas or in the more urban areas, more populated areas, that they are hesitant in getting the vaccine. And certainly the J&J news, the pause didn't help with that. So there's absolutely a segment of population. I think it crosses all ethnicities. It crosses zip codes. There's just a group of people that just don't want to get vaccinated, and it may not have anything to do with COVID. It may be against vaccinations, period. It may also be specifically the COVID because of misinformation or news that they read that they're concerned about, or their friend got really sick from the vaccine, so they're not going to get that vaccine. So there's a lot of misinformation out there in terms of what the effectiveness is and those kinds of information. So we seek to overcome those problems. And Paul, did you want to add to that?
I think I think as Jason said, it's the missing information or just bad information that many patients have, and then the biggest gap is many of the mass vaccinations we spoke earlier. The mass vaccination sites are they're they require an appointment. They require access to technology. They require you to have access to a phone, and there are huge swaths of rural North Carolina, Virginia, Tennessee, South Carolina, Georgia, where there is no high-speed internet connection. There is no cell phone connection. There is no easy access to the internet, and those are fiercely independent, self-sufficient people. And in that case, I think we see a hesitancy because it's like, well, I don't see but people at church every weekend, or I don't see people but at the grocery store, and that's once a week. And is it really worth it for me to take 3 hours out of my day to go and drive and try to find the vaccine? And it's just a lack of information about ease of access. And then another big barrier is the lack of access or lack of information for patients that it is in fact free, that is no cost to them, that it's being provided by the federal government. We've had some folks literally reaching for their wallet saying, "How much do I owe you for the vaccine?" It's like, no, it's you're good. Just here's your vaccine administration report, and we've got all the information that we need. And it's been interesting to see that just that little articulation of there's no cost, having patients who were hesitant because they know, okay, I've got $60 left in my account for the remainder of the month and I've got to eat, so I can't get a vaccine. All of a sudden, it's like, oh, well, that's a game changer. Let me go make that happen. So it's really just getting information out to patients and helping them understand the necessity of 75 to 80% of our entire population needs to be vaccinated before this is a quote end game for COVID.
Yeah.
Yeah, and
Well,
Matt,
so
if I could add one more thing to
go
that,
ahead, Jason.
you think about herd immunity, and herd immunity depends. We're talking about what herd. So again, Greater Nashville, which is where I reside now, I'm certain that we are probably approaching that herd immunity, and we'll get there. But in the rural areas of what we're talking about here, that's a different herd, and the immunity in that particular herd is much, much lower. And so it's not like the greater region of Nashville is going to have this herd immunity. When you look at the rural areas, it's pockets, and there will be pockets of herds that are just not getting the level of immunity, and we're going to continue to see problems like this until that gets addressed.
Yeah. So, Paul, you were talking about how you think, getting information out there and making sure people have the information, whether it's knowing that the vaccine is free or answering questions about it, sort of getting that information out there is really critical. So I know a lot of what you guys do beyond COVID is you have these clinicians call people up on the phone and talk to them about how they're using their medications and making sure they're using their medications right and communicating information about drugs that are not COVID-19 vaccines. And I think you guys have been doing a bit of that as well when it comes to the vaccine. So I mean, what are you guys doing to sort of make sure people have that information besides just setting up a clinic in the town or wherever you guys are?
Yeah. So what we do as a company, and this is no different on your question specifically with COVID-19 vaccination, is we typically work with whether it be employers or managed care organizations, and we have we have agreements in place from a security standpoint. We're high trust certified healthcare organization. We receive data. Now, this is medical diagnosis data, pharmacy claims data, managed care eligibility data, hospital discharge data every single day from our managed care partners and employer partners across the United States. We receive it every single day. Our analytics engine identifies who is at high risk, and then if the patients who are at risk go into a work queue that either our team of clinicians, our telepharmacy team, or our clients' clinicians, they can use this platform as a software as a service as well, drops into a queue. And depending upon the issue we're trying to resolve, in this case, COVID-19 vaccination, we will reach out to the patient and have a conversation about their medications, their food insecurities, and now COVID as well. Whether or not confirming that what we understand is that they haven't been vaccinated, because that would be the latest data we have. Sometimes it's not perfect. If they haven't gotten vaccinated, we discuss what may be the cause of that. It might not have anything to do with the COVID vaccination itself or access to it. It might have to do with the fact that they can't get off of work for during the week, and there's no ability to get to a weekend appointment. It could be that they're more focused on getting food in the refrigerator than actually getting vaccinated, or it's just not a priority for them. So we work on a patient by patient perspective to overcome and identify what are the problems that are preventing them from getting vaccinated. Absolutely, the area that Paul was just describing, the fact that it's free, that's an extremely important aspect of our talking points, what I would say. And so we document what those social determinants of health are, discrete data, and then we identify how we can overcome it. We try to overcome it on the phone right there. Sometimes we will connect them with transportation opportunities, give them phone numbers. Sometimes we give them access to areas where they can get food, Meals on Wheels, things of that nature, or food banks and churches. And sometimes we'll just give them information from a health literacy perspective of why the vaccine is so important for them to take. And then we, in that same call, typically 12, 14-minute phone call, but it's a meaty phone call because we're talking about important issues in their life and maybe their families as well. We're also then helping navigate, as Paul was describing, this is the technology aspect and the scheduling into a vaccination appointment. We're actually getting them scheduled into an appointment in their neighborhood, so to speak. And then we make sure that they understand the time, the date. Typically, these systems will give them a text or an email out of the scheduling system. If it's one of our mobile clinics, we would also do the exact same thing. It just depends on what is the easiest way for them to get vaccinated. The local CVS, a mobile clinic, a stadium, whatever the case may be, that we can actually schedule them on the fly or follow up with them after they've gotten their food insecurity issues overcome so that we can vaccinate them soon thereafter.
Yeah, I think that's a really good description. And it sounds like one of the key things there is you've got all this data coming in from insurers that kind of helps you identify, like, okay, who are the people that really are going to need the phone call the most? And then that's, kind of how you can prioritize who to call and sort of make the most out of those phone calls. So you guys have both mentioned some we've touched on this idea of vaccine hesitancy. And I think it's been interesting to hear both of you guys talk about it, because I think you talked about it in a similar way where, there are definitely some people out there who are just, they're not going to get the vaccine. They just say, no way. But then also, like, I think, Paul, you were saying, there's people out there who say, yeah, I only see people once a week and it's going to take me 3 hours to go get it. That to me seems sort of like a different level of hesitancy that interacts with sort of the access issues in a different way. So how do you guys think how does the demand for vaccines interact with the accessibility of the vaccines?
Well, and I'm going to ask Paul to provide some feedback on this. That J&J one shot opportunity is a really big deal. That's a game changer. The fact that there was a pause was really not helpful. We're very happy that was quickly overcome. But there are patients that have problems just getting to one shot. And then there's misinformation out there on if they were to get Pfizer or Moderna, that they may think that it's a very strict, they have to be there within 3 weeks on the nose to get the second shot. And they just can't commit to that because of maybe their job or transportation or lots of different issues, or they just don't like getting shots and they just not want to get a second shot. So Paul, maybe you can just give some real world examples of, we were actually in Hartsville, Tennessee, during the week of the pause with J&J. Maybe just give a couple of stories of what happened that week, if you could.
Yeah, exactly. Yeah, I'm happy to, Jason. We had one young lady who pulled up and saw the COVID vaccination clinic, and she looked at us, and she's probably in her mid 50s, and asked the question of, well, do you have to get one shot or two shots? I hate needles. I won't do it if I gotta get two shots. And we talked to her about the efficacy of the Johnson & Johnson vaccine. We talked to her about the difference between the two vaccines, at a very high level. Just basically said this is a one-shot vaccine. It protects you against severe COVID disease. And she was like, well, I've already had severe COVID disease. I was in the hospital for almost a month, and if this will stop me from getting it again in the next 6 months, where do you want me to park? I need to get to. Yeah, it's like, and then she then went and literally picked up friends and brought them back to the clinic to get vaccines, because she knew it was free, she knew it was a one-shot solution, and she knew that it was effective against severe COVID disease. And all of her friends had seen her go through the process of a 4-week recovery from a disease state that she frankly said point blank, she's like, I thought this was fake. I didn't think COVID was real. And then she went through the whole process. It is, and I'm not going to get it again. And so, and she went out and picked up friends and brought them to us. And then we had a couple of folks who came in and said, like, they just very, very hesitant. One gentleman is absolutely petrified of needles. Is actually a friend of mine. He's a 250-pound former Marine. And if he sees a needle, he gets weak in the knees and has to sit down. And he's like, look, I can get a one shot. There's no way I can force myself to do this twice. And so with Johnson & Johnson, we were able to help him overcome that. And of course, we also have stories of people saying, look, I can take a half day off, or I can take 2 hours off. It's important to my employer that I'm vaccinated, but I can't do that twice because of either we're very strict on time off, or maybe it's I'm new in my role and I don't just have the bandwidth to take more than one day off. And so, especially in Hartsville, it was very impactful to have the one shot solution. We actually had, when we came back on that Thursday, we had Pfizer vaccines, the 2-shot vaccines to provide to patients in the market.
And 2-day pause with the J&J.
Yeah, exactly. 2-day pause to get our logistics in place to get
Right.
Pfizer out to that clinic site and make sure we had all of our I's dotted and T's crossed on storage and whatnot. And it was really interesting because we had 16 people the second day we were out there, even though there was a federal pause, ask us for the Johnson & Johnson vaccine. Of course, we didn't administer it to them. We said, look, we'll be back in 3 weeks to give these guys their second shots. If it's back up, then we'll be happy to provide that to you. So we had 16 people say, yes, I want the vaccine, but I only am willing to get one shot. And so I think that's been our biggest opportunity. We also are servicing some intellectually and developmentally delayed patients down in Eastern North Carolina. And especially with the IDD population, you have some significant hesitancy because many of these patients have been poked and prodded and pricked their entire life, and they are very adverse to any type of medical care, and you're having to help them understand why they're getting a vaccine, what's happening, and then you have to be it's a much more empathetic and much more engaged process than it is with a traditional patient. And going through that process, I mean, we had a patient come to one of our clinics who got to the site, got ready to get his shot, sat down, and then refused. And his caregiver's like, let me talk to him. I think we can get him to take his shot. But he waited 2 hours, then came back and actually was able to receive his shot. Now, that's doable for one vaccine. That's a very heavy ask for that caregiver, for that patient, and for the administrator, the person giving the vaccine, to go through that process twice. And that's why we feel like the Johnson & Johnson is really giving us some opportunities to get into communities that we weren't able to see and talk to with Moderna or Pfizer.
Yeah. So I'm guessing you guys are pretty happy to see that pause lifted a couple of days
Extremely
ago.
happy. Yes. Yeah.
Great. Well, thank you guys for this conversation. This was super enlightening to me, just really helpful to kind of hear your perspective and what you guys are doing. I guess if people want to find out more about AdhereHealth, what's the best way for them to do that?
You could go to www.AdhereHealth. That's ADHERE health.com. Also, our pharmacy organization, which is a fully owned subsidiary is AdhereRx.com. So that's AdhereRx.com. And either one of those websites, I think you'll get more information on some of the things we talked about here today.
Great. Well, thanks for joining me on the show. This has been Medically Necessary. You can catch us next time on Thursdays on Apple Podcasts or on FreightWaves TV. So thanks so much for joining me on the show, guys.
Thank you, Matt.
Thanks, Matt.